So here today, I will deal with common and rare EGFR mutations. And sorry, I forgot my disclosures. I got a number of disclosure in terms of arrangements with pharma for scientific advisors and talks. And that is the contents I'm gonna touch today: common mutation and common and rare mutation. Some 85–90% of the mutation, of course, are the active 18 mutation on exon 19 and exon 21. Since the seminal work from Dr. Mox showing us that those patients with non-small cell lung cancer having the EGFR activating mutation, if treated with an EGFR TKI, they're doing better as compared to chemo, but if you're not having the mutation, you're doing a lot worse. So it's not only, as you see here, predictive, but also prognosis. Those data had also been consolidated initially in the Western trial led by the Spanish, Italian, and French groups, the UTAC, showing a lot of better outcome in terms of PFS as compared to chemo, and that has been further validated with every single trial with first generation, but also second generation TKIs as compared to chemo. Obviously, PFS was improved, but survival was a different issue. And here you see you have the data for the first generation against second generation TKIs. This is the case for the LANS-7 alpha versus gefitinib. Improvement, moderate in PFS, no impact on survival. The case for the dacomotinib drug was showing again maybe a higher benefit in terms of PFS, hazard ratio being 0.59. Remember, in this trial, patients with CNS metastases were not allowed. And significantly, you see here that most of the benefit was actually in Asians as compared to non-Asian. And importantly, no difference between the mutations for PFS. But in terms of survival, there was some benefit here as compared to what we have seen before with afatinib as compared to gefitinib. And indeed, in the sub-analysis, it was suggested that those patients that were Asians, particularly exon 21 mutations, were maybe extracting a most significant benefit. I'm not sure about the robustness of those sub-analysis, particularly PFS, not being that great in favor of exon 21, only survival. So, this analysis is always difficult to take out, and I'm not sure I would drive my prescription based on that. There were a number of attempts to improve the outcomes of patients treated with a first and second generation TKIs by adding bevacizumab, and eugenesis being a relevant signal here in this EGFR-driven disease. There was, with the combination of TKI plus Beva, a clear improvement in PFS without impacting survival. That was shown in at least some 2 Japanese trials, and that was reproduced with the anti-EGFR drug ramucirumab on the Relay trial, still pending on some survival analysis. The final effort was to combine with chemotherapy those first generation TKIs, showing a clear improvement, PFS, but also impacting survival into trials. So at this stage, where somehow some benefit was seen with second generation as compared to first, not sure impacted truly survival, some data, some signal on the combinations with anti-eugenics or chemo. We raised to the point of having novel inhibitors, the third generation. Those are the drugs we are using today for most of the cases in the clinic. as osimertinib have shown to improve not only PFS, but also OS of patients treated with osimertinib as compared to gefitinib. You see here the data, not only for patients with exon 19, but also exon 21, and survival benefit was always there. And of course, that was at the cost of not pretty relevant toxicity, or at least in comparison even with first generation TKI. So at the end of the day, I'm particularly taking into account the significant efficacy on CNS. Most of us, I would say, would choose third generation drugs as a frontline therapy. We are having now a number of other analogs, third generation drugs, lazertinib, furmonertinib. I just put in here the result of the Furlong trial, very much validating the Flora trial, very similar improvement or impact on PFS, hazard ratio 0.44, benefiting all those group of patients. And then we came to the point where the addition of anti-angiogenic is not being shown to improve the efficacy of third generation drug. This is true in the second line setting. We have a trial by the CIOT group, or even in the first line setting, as you see in this Asian study of Dr. Toy. The final two efforts that had been done trying to improve the efficacy of osimertinib, of third generation drugs in this setting, is the combination with amivantamab. I'm pretty sure Dr. Mock touched on the resistance mechanisms in the next talk. And this is one of the drugs that has been shown to have efficacy in the resistance setting. This duovoly that inhibits MET but also EGFR in combination with a third drug inhibitor, lazertinib, have shown to be efficacious, actually with a response rating of 100% in some only 20 patients, treatment naive with activating mutations of EGFR. And this combination is now being studied in a phase 3 trial. The other strategy that is maybe merit some words is the combos of chemo plus osimertinib. We have seen that the combos with third generation is effective, more than third generations alone. And here the initial data suggests in the OPAL trial that combos of platinum pimecrolimus plus osimertinib is also very promising let's say, strategy with responses in some more than 90% of the patients, and early data on PFS and OS are pretty promising. I'm not touching on the resistance, as Dr. Mock, I think, will deliver his talk with that focus. The second aspect I really like to comment on are on more uncommon mutations. And if we forget about the 85% of the mutations, the exon 19 and 21, that are somehow the ones that are seen in most of our patients in the clinic, we still having a number of other mutations that are coming once in a while to our consultation work. The most frequent of those being, of course, the exon 20 mutations, the T790M mutations, particularly in the relapsing setting, but the exon 20 insertions. At that point, I'm not pretty sure that we fully understand and have resolved the full structure, the crystal structure of that particular mutation. And it accounts for about, I would say, 3% of the cases of non-small cell lung cancer in Asian countries. They do have that specific mutation, and it's about 1.3% of the cases of adenocarcinoma in let's say, Western Europe and US. Of course, that is more or less on 5 to 7% of the cases among those with EGFR mutations. But of course, it depends a bit on the technology you're using to try to address that. Looking at the computational landscape, I don't think it's substantially very different what you see with exon 20 insertions as compared to other mutations such as exon 18 or 21. In terms of treatment today, we have mainly 3 strategies. One being the kinazoline-based drugs, mainly second generation afatinib and bosutinib, which of course, both of them being pan-HER inhibitors. Responses not that great, 14% bosu, 24% afatinib, and PFS not great either. Second type of drugs are the pyrimidine-based osimertinib. Actually, some trials showing responses in some 25% of the patients with PFS is particularly more appealing when using higher doses, 160 milligrams. And the novel inhibitors, mobocertinib and CLN-081 and subocertinib as well. Those drugs do have responses in the range of 30 to 40%, and of course, median PFS in the range of 7 to 10 months. And the third type of drug which is of interest is amivantamab, duobody inhibiting EGFR and MET, as we have commented, responses in some 40% of the cases, PFS in the range of 8 months, and having a survival of close to a year, median survival. Here just showing a bit more in detail the data of the CLN-081 drug that had been presented recently at ASCO. Responses in some 41% of the cases with the dose of 100 milligrams, which seems to be the right dose in terms of the looking at the efficacy profile. I do think there is a window of efficacy here, and here, as you see, the rate of diarrhea, stomatitis, and rash at these doses more reasonable, I would say. Some 30% of the patients requiring some reductions, and more frequently, patients requiring some interruptions. This is on a slide that Dr. Chan showed at the ASCO meeting, somehow highlighting the major difference. I would say for amivantamab, the main issue is particularly the infusion reaction. I feel it's very important to make aware all the medical team, all the day hospital team about how to handle that. Patients should be adverted about that because they do not have very nice time having that specific side effect, I think is, and of course you have to take care of the edema, hypoalbuminemia, and those typical MET type of class effects. For the TKIs, diarrhea, rash is more of a problem, asthenia being a problem, particularly that being a chronic toxicity that requires dose reduction very often. In that sense, the CLN-081 trial drug may be a bit much easier in the long term. Still, we have to define how good are those drugs in the CNS, how good are the terms of preventing the CNS relapse to happen, and indeed, how good is one drug after the other, how good are the TKIs on patients that had failed to amivantamab, how is amivantamab in patients that had already failed to TKIs. Those are some of the ongoing trials. In the first line, the Papillion trial, where patients are actually randomized to receive carboplatin plus amivantamab as compared to carboplatin. And in this claim to trial, carbapenem is compared to mobocertinib in this setting. The final few words would be for rare mutations. And of course, if we forget among the less frequent mutation, the exon 21, we have mainly three groups of mutations. The 719X mutation shown 3%, and then 1% of the cases being 76AI mutation or A61Q mutations. The others being a lot less frequent, including insertions on the 19 or deletions on the exon 18. Of course, those numbers are depending on the frequency, on the technology you're using, on the ethnicity, on the region. I mean, those may be more frequent on Asians, particularly, and if you use NGS as compared to you're not using, and of course, you're using NGS, you're going to discover a lot more compound mutations as compared that you're using only PCR-based technologies. In terms of how to better treat those patients, the first evidence was based on the second generation drugs being a lot better, at least across trials, in randomized trials, as compared to first generation. First generation typically do not work very well in these mutations. You remember the analysis, the joint analysis of the last line 2, 3, and 6 suggested responses in some 70% of the patients treated with those mutations, median PFS exceeding 10 months, and survival in the range of 20 months. As you should hear, the results being particularly appealing on those patients with the 76AI mutation or the 719X. On the contrary, those with the A61Q were not doing as well. Result not only true for in terms of responses, but also PFS data were aligned. In the contrary, those patients having the A61Q may be better served with a osimertinib, responses in the 80% and median PFS in the 15 months range. On the contrary, I would say those patients on the 76AI or 719X mutations may be having lower responses and lower duration of responses when treated with osimertinib. Indeed, retrospective studies were looking at the same question actually suggest very much the same. Those patients with the LA61Q mutation, maybe they do better on osimertinib. On the contrary, patients with the 719X or the 76AI, they do better when treated with the second generation. Of course, now we are having a better idea on the structure function classification of the different exon 20 insertions that may be of help to understand a bit better why mutation on the same exon may induce similar changes in the receptor structure and having the same type of sensitivity, and on the contrary, different structural effects depending on the drug interaction with the P-loop or with the alpha helix may have impact on the way we should treat our patients. Just a final word to compound mutations. Very often we have more than one mutation. That is having different doublets of common plus common mutations, particularly common plus uncommon or uncommon plus uncommon. What is true is that those uncommon mutations are likely to be the ones telling us how it's going to be the response, how it's going to, the patient is going to respond, and how is maybe giving us an idea of which drug to use for those specific patients. And here you see a panel a bit of what would be the expected sensitivity and resistance depending on the compound mutations here you have. So in summary, I just like to say that at present, third-generation drugs are the main treatment for patients with classical mutations. At this stage, we are testing some combinations, particularly chemo plus or amivantamab, and maybe anti-eugenics is not, we are not that interested on. In terms of exon 20 insertions, we are having two clear alternatives, TKIs and amivantamab. We have to define what is the best strategy, the best sequence, and a couple of phase 3 trials are already ongoing. And in terms of the more uncommon mutations, I think we have a good idea. Second generation drugs may be the of choice, with exception of some specific mutations such as the A61Q, for which maybe osimertinib is the way to go. So thank you very much, and I'll be happy to answer any question at the end of the session. Thank you.
But thank you very much for the opportunity to talk about targeting osimertinib resistant. I think following what Luis had just said, osimertinib is a popular drug. This is my disclosure, and more specifically, I'm board of director of this few companies. Now, a humble beginning with personalized medicine based on the first generation TKI, better than chemotherapy. 10 years later, we have a third generation drug, osimertinib, proven to be better than gefitinib and erlotinib, and done both in terms of progression-free and overall survival. So now, based on this data, we still have to take the next step, is that how do we manage the resistance? So I'm just going to go on 3 areas. Let's define the resistance because it's relatively complex. And then what is our current treatment strategy? And last but not the least, to touch on the role of immunotherapy for the osimertinib resistant at this moment. Starting with defining the resistance, one of the best so-called, in my opinion, summary is from lung cancer by Dr. Schmidt and also by Dr. Natasha Lyle from University of Toronto Princess Margaret Hospital. They define the resistance of mechanism into EGFR dependent and independent. And the independent, they look at the linkage plasticity, which possibly everybody knows is a small cell transformation, and also alternate pathway. Now, on the EGFR dependent side, they actually look, the most common one is C797S, and on the top of that, there are a number of so-called uncommon mutation that Luis had touched on. Let's dig a bit deeper into the situation. How common and how likely they are. So based on this review, as you can see, is that whether you go on first line osimertinib or second line osimertinib, the pie chart actually look awfully similar. Now, as you can see that there is a good segment of the patient who are actually having the so-called the MEK inhibition and the HER2. So this is an alternative pathway, which get a reasonable size of the pie. But then another bit of the pie is a green one, is meaning unknown. So in other words, we still have a lot of untapped resources we may look into in the future. But right now, if you want to put it in a clear fashion, which is based on the plasma test from FORA and AURA study, so it's a real-life data, that you can see whether you can, from first line osimertinib, which is FORA study, and second line osimertinib, C797S is there, about 7 to 15%. MEK is about 15 to 20%. So those are two we can target, and there's a small bit of the HER2 amplification, which potential we have dropped. And then we have a whole bunch of miscellaneous. Now, this is actually captured by Garden, which is a plasma-based NGS that look for about 71 genes. So it's not comprehensive. That's why we still get a big chunk of unknown right here. All right. But take on the biology a little bit. I think it makes sense about the C797 mutation, because that is exactly the binding site for the third generation drug. The WC4002 is actually the prototype, the first third generation drug. This drug never got developed, but then all the other drugs are developed based on this molecular structure or a pyrimidine-based molecule. And you can see that it makes perfectly sense that there is a resistance occur here, and therefore the drug can no longer bind. So it is some way that we can potentially do something about, which I will talk in a moment. In the alternate pathway, as you can see that there are dimerization of EGFR and other HER family, but once they got inhibited, then there is a potential of MET amplification. And with the MET amplification, then it can actually, as a bypass a signaling pathway down the RAS pathway. So again, it makes perfect biological sense that it is another target that we can aim for. So with this too, let's look at some of the data that we may have at this moment, where we are in 2022, and what are the directions we're heading towards to. So early on, there's already this discussion of the third generation drug. So one of the so-called early molecule that was discussed is a heterostatic compound, JBJ 04212502. But the development is kind of slow. So it's kind of allostatic compound that's more specific for exon 21 and T790M and the C797 altogether. So the preclinical data look promising, but I don't have any clinical data to share. After that, there is a similar molecule, which is a Blue 945, as stated here, and they do have the blinding on the alternate site, apart from the C797. The early preclinical data look promising in a way that you can see that they got a rather impressive IC50 when you have the so-called resistant occurring right here with the cell line of the 1975. Then, you know, when you look into the potential of the so-called different pathway, then this actually exemplifies that Blue 945 may actually have sensitivity in all the different mutations. So the data early on is fine. So the only data we have is from this year ACR, the Symphony study. This time is a combination of Blue 945 with osimertinib in a combined dosage, and then looking at a bit of the expansion cohort data. Now, I was kind of expecting some good response rate, but right now they only get the data on the reduction of the ctDNA. Now, we can say, yes, it's kind of interesting, but it's not the same as the tumor response. So you see this nice little curve with the number of patients with C797S in the plasma, there were reduction in the ctDNA. I don't know how to take this further, but I certainly will wait for more mature data to see whether we have any genuine tumor response before I take on the concept. Amivantamab, a bispecific antibody that everybody know well since it's approved for exon 20 insertion. It does have a role in combination with lasatinib, which is a third generation EGFR TKI from Korea. Now, so this is actually the data by reported by Kevin Su in ASCO this year, which is an update. They look into the expanded cohort of the lasatinib and the amivantamab, and then endpoint is the overall response rate. So there's more mature data and also in the large sample size. They total have 162 patients, and then most of them had a number of treatment before. So they are not the easiest treatment type, but then they still attain a 33% of a response rate and the median duration of response about 10 months. So this is nice, okay? But we still have to move on to say what else we can do. Now, if you look into this data set, it's the question of who may benefit. So they got different color bar. One group is the osimertinib followed by chemotherapy, and then go on this amivantamab lasatinib combination. Another group is first generation drug, osimertinib, and then platinum chemotherapy. And then the other one is the multiple line without sequence. Now, there's no specific pattern. Which one is better? Response rate, 21%, 36%, and 39%. But one thing I have to remind you, though, so it's kind of nice that this 30-some%, but the patient had chemotherapy. Some of this could be a result of rechallenge with the TKI. So whether it is the amivantamab that add on the extra edge to it, or whether it's a recharge phenomenon, I think we really have to look into this very carefully. And so before we just commit this as a standard treatment. But I'm hopeful for the outcome. Most of the day, most of the patients who get positive response, they actually stay down quite nicely, so that the result is actually relatively durable. Now, that is for the MAC. That is for the amivantamab. But then for the MAC, now we have two MAC agents available, comatinib, tepotinib. But there's a third one called savolitinib. The data set is from Hatton study. This is actually from WCLC 2020. Patients have to be MAC amplified, defined as a gene copy number over 5, or the MAC CYP7 as over 2, or IHC2 plus or 3 plus, or by NGS. So with the 3 or 4 different cohorts, part A is the post-osimertinib, and they got MAC amplified, they go on savolitinib and osimertinib. The second part is the first generation TKI, and then when they fail, they have the T7M negative. This one is that when they're T7M positive. Cohort D is actually an expanded cohort of B2, same population, but they use a lower dose of 300 milligrams daily. Now, the first part, when you fail osimertinib and you MAC amplified it, you go on and MAC inhibitor savolitinib plus osimertinib, you have a 33% response rate, which is quite nice. I mean, in a way, is that this is immediately failing osimertinib, and you add on a MAC inhibitor, you still have 1/3 responding. The next part is the fact that the patient is T7M positive. Well, T7M positive, you got osimertinib plus a MAC inhibitor, you got 67% response rate. This is expected. There's no big deal about it. But these two cohorts are the T7M negative. T7M negative, we don't expect the response rate from osimertinib. But because they are MAC amplified, we're looking at 65 and 62% response rate. Sample size is not small, 51 here, 42 here, almost 100 patients. So I think this part is quite promising, but these are post first generation. So if you look at progression-free survival, it's about 10 months here and 9.2 months here. And when you compare to IMPRESS study, first generation, if you failed the TKI and then go on chemotherapy, your median progression-free survival is about 5 to 6 months. So now with the combination of a MAC inhibitor, we're talking about 9 to 10 months. So there's a good chance that it may win. So there is a phase 3 study going to start. It's called the SAFFRON study. The detail will be coming out soon. Now, another approach is to give a ADC. So the ADC may potentially target the MAC. And the one that is actually being reported is by Dr. Goldman in ASCO this year. And then the TKI is actually TESIO-V. And then it gets a rather potent so-called the cytotoxic drug linked to the anti-MAC antibody. And so this is the dose escalation with the dose expansion. Now, early data, but you do see that there are a good number of responders. And then if you look at the dose, there were the total number of about 19 patients. And then so the so-called is a reasonable size, and the response rate, 11 out of 19 responded, which is 58%. So small sample size, but a promising response rate. And then it does not differentiate whether it's a mutation type or whether it's a CMAC expansion level. So I think early data, but I think we have to keep that in mind. Potentially, it may become a treatment. But there's one so-called the toxicity that we need to worry about, peripheral neuropathy, which is likely due to the cytotoxic drug that's linked to this agent. And also there is peripheral edema, which could be the class effect of the MAC. So the toxicity profile that we have to watch out in the small study. Another ADC is actually that's the so-called the patritumab, that's a TKI, and it is a HER3 DXd. Now, Pasiani actually reported earlier on, but then published in Cancer Discovery a few months ago. It is a potent ADC in a way is that they got the linker ratio about 1:7. So there is actually a good number of payload included in each monoclonal antibody. So their data is actually based on 57 patients. Response rate is actually 39%, median progression-free survival of 8.2. The overall survival is not reached yet. Now, there is no specific differentiation of which type of osimertinib resistant may get a better response. So at this moment, you got a reasonable response rate of 39%, close to 40%. We don't have a biomarker. So let's look at HER3. Well, when they look at HER3, you can see that whether you get partial response, stable disease, and progressive disease, same. There's no specific evidence to say that high expression will end up in better result. So it seems like a good drug, but we don't have a good biomarker yet. But we're going to move forward. So this is a HERTHENA study. This is patient who failed osimertinib, the third generation drug, and now they got randomized to either patritumab and the deruxtecan versus the standard chemotherapy. And so this study hopefully will start very soon, sometime this year. And then this will help us to define so-called another standard treatment post-osimertinib. So that is data that I would like to share with you in terms of the use of the target therapy for the known resistance mechanism. Now, immunotherapy is everywhere. Everybody use it, and I'm sure that you will have many talk about it. But then for EGFR specifically, we got one issue. That is the tumor microenvironment. The EGFR mutation positive lung cancer are more likely to be in never smoker. They got a single gene mutation. So therefore, the so-called the microenvironment proper is quite different from a heavy smoker. So there's a number of things that we should pay attention to in this environment. One is the Treg cell situation. The other one is CD73 and adenosine. And of course, there is a relationship with the PD-L1 expression. Now, so basically, I mean, there are less high PD-L1 expression of the EGFR mutation positive patient. CD73 is actually a endocyne that actually produces the induction into the production of adenosine, which will put a sedative effect of the white cell and the T cell, as well as other myeloid cell. And Treg is actually may have a inhibitory reaction with the EGFR as a resulting in the Treg regulation. So as a result, all these microenvironment may directly or indirectly affect the outcome. And of course, we do observe the fact that there are lesser of response to immunotherapy with the patient with the EGFR mutation. Now, of course, there's an IMpower 150. Looking at this subset that is interesting. And then the data is promising in a way is that the 4-drug regimen in the mutation positive is actually better than Taxol, Carbo, and bevacizumab in terms of both progression-free and overall survival. Now, this is good, and I'm sure that a lot of us are having it. But this is a subgroup analysis on 100 patients of a phase 3 study. This is not really a independent study. So we should not act as if it is. So we do need more data. Now, last year in ESMO, there is an Orange 31. These are the patients who are EGFR mutated, failed TKI, and now they have to randomize the two, the cetirizumab, which is a PD-L1 that is made in China, and there's a biosimilar I305, which is a so-called kind of like bevacizumab biosimilar, and then together with chemotherapy. Compare with the arm C with the chemotherapy alone. Now this one is actually just like the IMpower 150, that is without the anti-androgens, but they did not report the data. So they only compared the A to C. So in ESMO, they actually reported improvement in progression-free survival, 6.7 versus 4.3, and that's improvement in response rate. But there's no overall survival benefit, no overall survival data that has been reported. So it's kind of promising on the 4-drug regimen, although it's not exactly IMpower 150, but the concept itself is actually supportive. But we remind you that both of these drugs are not available outside China for the time being. What are we looking forward to? Well, there are other studies. There is IMPA 151. This is focusing on EGFR ALK. They allow 50% of the population here to be EGFR ALK positive. Chemo plus bevacizumab versus chemo plus bevacizumab plus atezo. Now, the chemo, instead of taxol-carbo, they use pemetrexed, which is more friendly for us to use. This study is actually almost complete accrual, and hopefully we get some answer in the near future. Now, quick word on adenosine. Now, CD73 for the MP, they will produce adenosine, and then adenosine on the T cell, there's a A2A receptor. Once it's activated, then the T cell activity will reduce. So, and that this CDC is so-called the activated when there is a binding between the T cell receptor and the MHC. So this is kind of a mechanism for us to say that potential target. So anti-CDC, there's a already monoclonal antibody called alucumab. And this year, or last year, in the COAST phase 2 study, they have a data looking in the durvalumab as a single agent versus durvalumab plus oculumab plus another so-called the monalizumab. So in this study of a phase 3, the stage 3 patient, then you will see that the response rate is 18% single agent, 35. And there is higher in terms of the progression-free survival. So small study, 60 patients per arm, but it does carry a message that potentially anti-CD73 may be working. But to remind you, this is not directly on EGFR. So let me just summarize. In the mechanism, I think we have multiple. They are EGF dependent. We need to focus on C797S. It makes biological sense. Non-EGFR, we got the linkage plasticity from the small cell, and also alternate pathway like MET amplification, which we can target. And now we do have a blue 945 non-specific target. We get bispecific antibody, MET inhibition, savolitinib and osimertinib, ADC with anti-HER3 DXd and TESIO-V. And on immunotherapy, I think the concept of chemo plus PD-L1 plus angiogenesis work, but then certainly I think that we should wait for some of the prospective randomized study. And we should also keep our eye on the development of anti-73 and adenosine inhibition. So that will conclude my talk. And certainly this is something that I will miss in Milan. So a Saffron risotto. But then I'm sure that I'll come back sometime in the future to sample it. Thank you so much, Filippo and all my colleagues.
Get up there. And of course, today we're going to talk about targeted therapy for fusion-positive lung cancers. These are my disclosures. All right, so we're going to go in steps. And the first section here, we're going to deal with my approach to treating a patient who has stage 4 lung cancer, harbors one of these fusions we're going to speak about, and is also treatment naive. And the first thing I wanted to focus within this section is that there are many different fusions in lung cancers in general. And so it's really a histotype where you see enrichment for these recurrent gene rearrangements. As you can see on the left, while these are found in lung cancers, these are also found in many other tumor types, giving rise to some of the trial design strategies that you've heard about for genes such as NTRK that are actually becoming much more popular for other fusions as well. But if you move to the right of the slide, an important reminder is that these fusions obviously have varying levels of clinical actionability based on the data that's out from the prospective clinical trials. And of course, on the upper right, if you have a fusion involving ALK, ROS1, RET, or NTRK, that we have very high confidence that we have targeted therapies that are highly active, that are positioned in the first-line space, and achieve outcomes at least historically are better than our prior therapies, such as those that include a platinum doublet. However, on the lower right, as a reminder, because especially as we migrate now to comprehensive genomic profiling, and you've heard from Dr. Peters, that many of these assays do have a discovery component. If you do RNA as well, you may pick up these fusions, but there are several other recurrent gene rearrangements, NRG1, MET, BRAF, FGFR, etc., where our confidence in the available data obviously is not as high. And so the approach here is to start with standard of care therapy, platinum doublet inclusive, and then later consider a clinical trial or later line chemotherapy, knowing that some of these trials are actually treating treatment naive patients. So we'll see how the data emerges in those populations. But we're going to pull out ALK, ROS, RET, and NTRK. And as we mentioned, because targeted therapy is highly active in these fusion types, that we start with a tyrosine kinase inhibitor. And the next section will really focus on the contemporary TKIs that are available for patients with these fusion-positive lung cancers. And this is a selected list. It's not comprehensive by any means. But you'll see here that a lot of the second, third generation agents have baked in principles that we know have improved drug design over the years. And so many drugs have focused on including intracranial coverage or CNS activity. A lot of them, as you can see here, have also folded in coverage for on-target resistance. So mutations that occur at the kinase domain that render these tumors resistant to earlier generation agents or multi-kinase agents for RET, for example. And we're also moving into an era where drug design is getting much more thoughtful, that we have agents that are highly target selective. And the prize there, obviously, is that you avoid off-target toxicity that might lead to an increase in side effects. Now, which tyrosine kinase to choose for these individual fusions? This will, of course, be highly colored by my own biases, but we'll go through the data that's available, and we'll start with ALK fusion-positive lung cancers. And just a quick mention that ALK has really led the way in the fusion-positive space, and we have randomized trials where you have later versus earlier generation TKI therapy vis-a-vis alectinib, brigatinib, lorlatinib versus crizotinib. And here you see the gains in the first row in terms of progression-free survival, and in the second row below you have gains in terms of intracranial coverage, duration of disease control. The punchline, of course, is that these TKIs have given us improvements in these outcomes compared to crizotinib. But unfortunately, the decision to use one of these later generation TKIs is not yet informed by head-to-head large-scale randomized data. And so we still have these cross-trial comparisons that come with the caveats of comparing across trials. As you can see, response rates are high, progression-free survival looks good across the drugs where it's available. And the hazard ratios, we'll talk about that in a second, but thus far lorlatinib with a CROWN trial has given us the lowest hazard ratio for progression-free survival. The decision on which to choose obviously is also based on side effects, and you know that these drugs have different profiles, as you can see summarized on the right. Pulmonary events, for example, for brigatinib, alectinib can have a higher frequency of transaminitis, and hyperlipidemia, triglyceridemia, and cognitive effects with lorlatinib. The overarching question is, because lorlatinib has the lowest hazard ratio, should we use it versus alectinib or brigatinib? And this has been a point of controversy. Very interesting that the JTO highlighted this in one of their issues, where you had Dr. Kamij, Dr. U, and Dr. Nagasaka writing about one position versus another. Of course, the argument to do lorlatinib as championed by Dr. U and Dr. Nagasaka in this opinion piece is really contingent on the drug having the lowest overall hazard ratio. It may provide the most optimal CNS coverage if you consider factors such as the CFS plasma ratio. It also does have coverage for kinase domain mutations broadly that other drugs like alectinib doesn't. But the counterpoint here, if you look on the right with Dr. Kamij's paper, is that really toxicity can be an issue. And many patients, this is apart from the 90% frequency of hypertriglyceridemia, hypercholesterolemia, can have cognitive changes that can substantially interfere with quality of life. So I'll share my approach. I think I'd like to see more data come out regarding which drug to choose, but there's a lot of inertia to use alectinib in my practice compared to lorlatinib, which I tend to reserve for sequential TKI therapy after a patient fails on alectinib or brigatinib, if that's your choice. Now, which TKI to choose in ROS1 fusion positive lung cancers? So we have less data as we go away from ALK. And it's important to recognize that the trial, of entrectinib versus crizotinib were not randomized. And the trial populations were very different. So if you look here at this summary, you'll see that crizotinib versus entrectinib, there was a big difference in the proportion of patients that had intracranial metastases at baseline. The entrectinib trial was highly enriched, so more than 40% of patients had brain mets. And you'll see that Profile 1001 had none that were reported, even though there were some patients that were treated. And ONC, the largest study thus far, had a little under 20% of patients with brain metastases. So you'll see that if you focus on median progression-free survival, that there isn't a big difference if you look across crizotinib and entrectinib. And in fact, in the most recent update that we published in JTOCRR, these numbers are starting to drift down. However, I think that if you focus now on the very right hand of the slide, you'll see that entrectinib still has the most well-characterized intracranial outcomes. It does, in preclinical data, have better coverage of the CNS compared to crizotinib. And so given this data, more of the intracranial data that you see here, plus real-world evidence. So this is a paper from Dr. Doble using the Flatiron real-world evidence data set comparing patients with ROS1 fusion-positive lung cancers that got crizotinib versus entrectinib. You'll see that the curves do diverge in terms of time on treatment or overall survival. So I'll share that my preference in clinic is to give entrectinib for patients, given all of the caveats that you've heard. But keep in mind that entrectinib also has activity against TRK, so it comes with a baggage of TRK-related toxicities such as weight gain, dizziness if patients are very sensitive, and withdrawal pain, which can be very bothersome. For those of you that have treated some patients, if they have to come off temporarily or permanently, they can have full body myalgias, and you'll know that it's absolutely a drug effect, because in those that come off temporarily, when they go back on entrectinib after the first pill, within the first hour, it's completely gone. So you know that it's a function of the drug rewiring the threshold for feeling pain. And it's something that we need to pay attention to, especially if they can't stay on entrectinib if you're going on to a subsequent therapy. Now, which drug to choose for RET fusion-positive lung cancers? So here you'll see the regulatory data sets for selpercatinib and pralsetinib, both of which are approved in one or more regulatory environments. High response rates in the treatment-naive and pre-treated state, and you'll see the difference in median progression-free survival, both overall and intracranial. You'll see that the confidence intervals here overlap. So I don't see a dramatic difference between the two TKIs. So for me, it does come down to also the side effect profile. So just to call out for you, there are in the bolded font here in the tables, common side effects such as hypertension. Even though these are selective, I think you do still get some inhibition of VEGFR2. And you also have transaminitis. But selpercatinib does have more dry mouth. We don't know yet what mediates that. Some edema. In my practice, it's more periorbital. And then we just shared this at ASCO this year, but you can see chylothoraces emerge. Very interesting. And the usual patient will be you have effusions that are growing in the lung or ascites, but everything else in terms of tumor nodules or masses remains nicely under control. And I advise you to look carefully because you could confuse this with progression. and think that your patient has pleural or intra-abdominal progression. But if you tap the patient, you might see a very obvious chylothorax, as you see here. But there are some cases where it's not obvious, but you do a triglyceride level and it's above the cutoff for a chylo, and you know that you're dealing with a side effect and not true progression. Now, in contrast, if you look at pralsetinib, because it does inhibit JAK2, you see much more myelosuppression. So if you have someone that's hopping on this with issues with their bone marrow or blood counts, then you might want to prefer salpercatinib over pralsetinib. In my practice, I'm very biased. I was highly involved with salpercatinib. I start with that first. But I've heard others who preferentially do pralsetinib first. NTRK fusion positive lung cancers, we have some updates at ASCO this year. You'll see that across larotrectinib and entrectinib, larotrectinib is selective, entrectinib also inhibits ROS1. You'll see high response rates, including in patients with CNS metastases for both drugs, highlighting the intracranial coverage of these TKIs. And the update, of course, is in terms of durability. So at ASCO, we presented the lung cancer data for LARO, and the medians for duration of response, PFS, and OS has still not been reached compared to entrectinib, where you see the numbers here. So because of selectivity and because of the durability data, my preference is in an NTRK fusion positive cancer, I tend to use larotrectinib over entrectinib. Now, how do you treat someone who has a cancer with a fusion that's progressed on TKI therapy? Of course, you consider things like how much cancer do they have? Are they symptomatic of their cancer? Do you have time to repeat molecular profiling? And if someone has a large burden of disease, has never seen chemotherapy before, is very symptomatic, I often will choose chemotherapy first. Especially if you haven't resequenced someone's cancer and aren't quite sure that you're dealing with bypass resistance. But we'll start with cases where perhaps you have time to resequence, you have coverage for resequencing, and you know that you have on-target resistance. Well, in these cases, I would look to another tyrosine kinase inhibitor. We know that on-target resistance is mediated by acquired kinase domain mutations that are interestingly paralogous to each other. Many of these at the different motifs called the solvent front, the gatekeeper, etc., are paralogs of each other. And when you find one of these mutations and nothing else, we know that this might enrich for benefit. So this is a few years old now. This is from Dr. Shaw, showing that patients who are ALK fusion positive, who progress, that on resequencing have an acquired kinase domain mutation, they may have a higher likelihood of response if you find that in plasma or in tumor. And you see the PFS curves on the right. Now, in patients with ALK, you know that you can use lorlatinib, which you saw in the prior slide. But for ROS, RET, and NTRK, you would need to look at a clinical trial for one of these next-generation TKI therapies. And we'll begin with ROS1, where just a word of warning, the activity of certain next-generation drugs is conditioned by the fusion that it acts against. So while lorlatinib really has excellent coverage for many kinase domain mutations in ALK, just remember that it doesn't work as well in the context of a ROS1 fusion. And here you'll see that on the left, the clinical data for lorlatinib in the recalcitrant solvent front mutation state, you don't actually see confirmed responses for ROS1 G2032R versus newer agents like repotrectinib, where you have confirmed responses in solvent front mutants. We also saw data from taletrectinib, which is another drug which inhibits ROS1. So make sure you pick your drugs wisely and make sure you look at the profile of resistance. What do we have for NTRK? Well, we have two drugs, selitrectinib, the data of which you see here, which is several years old now, presented by Dr. Hyman. The drug does work in the face of solvent front or gatekeeper mutations. And note that repotrectinib, the drug that we saw in the last slide, we're also starting to see data for NTRK fusion positive cancers for that TKI. Now, this was mentioned with EGFR, and we'll see parallels with ALK as well, But there are some tumors that when you expose them to sequential TKI therapy, you may see the emergence of these compound mutations where you have 2 ALK mutations, 3 ALK mutations. This is an example from that cancer discovery paper 4 years ago, where you see someone move from crizotinib to brigatinib to lorlatinib, and you now have this triplet mutation. And often in our hands, when you look at the sequencing, a lot of these are in cis. So you know that they really interfere with drug binding. So the last thing I'll say is that don't automatically assume that tumors will migrate towards on-target resistance. This is updated data for RET, where unfortunately, if you look at pralsetinib in the middle pie and selpercatinib in the pie on the right, the frequency of acquired on-target resistance is low, meaning that patients will acquire a RET kinase domain mutation by itself in about 8 to 10% of cases. So this also means that with the next generation drugs, I'm not sure we can assume that we're going to see high response rates just because of this phenomenon. Okay, this is why I think it's important to sequence. But the good thing is that if you do find these mutations that summarize in this table, and again, not a comprehensive list, there are many new agents that are emerging. Some of them, like TPX0131 and VL655, will cover doublet, triplet ALK mutations. You see for ROS and RET new drugs such as NVL520, which is a highly selective agent. For ROS1, we have HMO6 and LOXO260, which cover the solvent front 810 substitutions, and also gatekeeper mutations, and the other drugs that we mentioned in this section. Now, when to do chemotherapy, we already talked about someone who's symptomatic, but it also should be thought about very carefully in someone that has off-target resistance. Many of these cancers will reactivate the MAP kinase pathway by mutating RAF or MEK, and so reestablish downstream signaling. The figure here is for ROS1, but it certainly applies to the other fusions. Plus, also, you might get very excited if you, let's say, do plasma sequencing and find a kinase domain mutation. But keep in mind that these can coexist with off-target resistance. And so this is a case from our center of a patient who received selpercatinib, but on resistance had polyclonal resistance to therapy, where you have both RET mutations, as you can see in pink, but also multiple KRAS mutations. And in this case, I would reach for chemotherapy because obviously it's unlikely that a next generation TKI here will work. So clinical trials we spoke about for the on-target resistance. The same applies for off-target resistance. There are some cases where off-target resistance is simple. So again, going to RET, some of these cancers can acquire MET amplification after treatment with a selective RET inhibitor. And we published on the right that if you do a combination of a RET inhibitor and a MET inhibitor, in this case, crizotinib was added to selpercatinib, that you can reestablish disease control. And just to show you here that there are many different approaches to combining therapies for these fusions. There are SHP2 combinations now added to lorlatinib, for example. And there are other combinations such as MEK and MET inhibitors. Finally, as you've seen with EGFR, there is some data. This is our paper on the right showing that you can add something like bevacizumab or another anti-angiogenic to an ALK TKI and reestablish response. I know I'm over time, so very briefly, immunotherapy unfortunately doesn't work very well for fusion-positive lung cancers across PD-L1 expression levels, including PD-L1 high patients. And you'll see that response rates are low, and so is PFS. What about chemoimmunotherapy? Well, this is a paper we published with ROS1 showing that you do very small numbers, but you do get more responses when you add chemotherapy to immune checkpoint inhibition and you have some durable disease control. But the issue, of course, becomes toxicity, because we know that if you're going to jump on a TKI after someone's got immune therapy, that side effects may be pronounced. Here we see with selpercatinib hypersensitivity that can occur in the wake of prior immune checkpoint inhibitor therapy. So this is going to be explored in the next section for early stage disease. So I'm going to skip over this slide and conclude. To summarize what we spoke about, do consider giving a TKI to treatment naive patients with the fusions that we spoke about. In patients who progress, I do try to get resequencing of either plasma or blood, as that can be informative for either sequential TKI therapy, combination therapy, or chemotherapy. And finally, immunotherapy does pose its challenges. The overall activity is low, and it may increase side effects with subsequent targeted therapy. And with that, thank you for your attention.
Great, thank you. And thank you, Filippo, for the invitation. Always a pleasure to join you here in Italy. When I look at these three mutations in this next section, it may seem like these are just the ones that were left over. But actually, I think that Filippo and Nicola really put these together for a reason, because these three mutations, these actionable targets, really do have a lot in common. These are my disclosures here. When we think of these alterations, they are actionable. They have FDA-approved targeted therapies. But what makes these unique is that the patients that develop these alterations are a little different from some of the fusions we've just heard about from Alex. First, from a demographic standpoint, all three of these regularly occur in smokers. And perhaps related to that, we can also regularly see responses to immunotherapy. And so immediately, while these are targets, this is a targeted therapy session, these targets are a little different. BRAF MET, commonly in smokers. KRAS, the relevant mutation there, G12C, almost exclusively in smokers. Right? When we think of our biochemistry and why we learn those things, KRAS G12C, glycine to cysteine. So glycine is a GGT, cysteine is a TGT. So a G to T transversion is from exposure to an aromatic hydrocarbon. And so that's almost always going to be related to tobacco use. So these three, I think, are linked. I think it makes sense to consider these together. Let's start with BRAF mutations. These are present in about 1% to 2% of lung adenocarcinoma, again, regularly seen in heavy smokers. We're going to classify these functionally as V600E and non-V600E. That does have treatment implications. There are different types of BRAF mutations, classes 1, 2, and 3, and those are fundamentally different. Really, class 1 is what's relevant for therapeutics. Class 2 and 3 generally don't respond well to BRAF inhibition. When we look at the early efforts, largely from Gustave Roussy, we saw that dabrafenib, an oral BRAF inhibitor that really cut its teeth in the melanoma world, showed responses about 33% in BRAF V600E lung cancer, but we did see, as we saw in melanoma, about 12% of patients developing cutaneous squamous cell carcinoma, really from a paradoxic overactivation of that RAS pathway. When we add a MEK inhibitor, in this case trametinib, we see that response rate shoot up, almost double, and the incidence of cutaneous squamous cell carcinoma cut down by down to a third, and only 4%. And so dabrafenib, trametinib, very effective. Here we see in pretreated population a response rate 63%. And in the frontline setting, very consistent actually, response rate here 64%. These data were recently updated, and this was FDA approved in June of 2017. And with more time and longer follow-up, again, pretreated and frontline behaving very similarly, response rates north of 60%, PFS just under a year. These are now an accepted standard of care. Now, I know that most of us have given these drugs. They do have toxicities, fevers, GI toxicities, but I think overall these are well-tolerated drugs, and for some patients, as shown in that swimmer's plot on the right, can be effective for years. And so really have transformed this specific alteration, but we know that for most patients, these will be transient, these will be temporary responses, and we do see resistance, as was alluded to by Alex. When you're dealing with a central pathway, like the MAP kinase pathway, resistance is very difficult to overcome. There are many moving parts here in such a central pathway. There's a lot of redundancy. As a result, resistance tend to be very heterogeneous, and most of the selective inhibitors in this setting have been disappointing. Generally, upon resistance, we're looking more towards chemotherapy, or in some cases, immunotherapy. When we think about METX14, and I borrowed this figure from Alex, showing the biology of METX14, it's important to remember how this works. It's not a single kinase domain mutation. Normal physiology, the MET transmembrane receptor, is targeted for destruction by CBL, CBL. And CBL binds, it labels MET for ubiquitination and then degradation. When you skip exon 14, you're skipping that binding site for CBL. And if CBL can't bind, CBL doesn't bind, it doesn't label MET for degradation. As a result, there's too much MET signaling, and that is oncogenic in nature. METX14 mutations seen about 3 to 4% of lung cancer, and again, seen in smokers and non-smokers. I think think the big question we have is, are those different diseases, and should they be managed differently? As Solange mentioned earlier, detection here will be enhanced by RNA-based next-gen sequencing, and while it does add cost and it does add some time for some of these alterations, especially METX14, where you have a lot of tandem repeats, DNA-based NGS will miss some of these alterations. So if you're not doing RNA-based sequencing, you may be missing some METX14. Data at the bottom here from one of my fellows at Georgetown looked specifically at METX14 mutations, and in that X14 group, about 470 mutations, she counted no less than 147 different mutations. And we did see clusters there that influence biology, where we see changes in TMB, changes in PD-L1, and so as time goes on, we're only going to get more granular, more specific with these alterations, because all these differences probably do matter in some way. Crizotinib was really one of the first drugs that showed activity here. These are data from Profile 1001, looking at 69 patients with METX14 lung cancer. While this is a trial that we associate with the approval of ALK, the approval of ROS1, with crizotinib, the original protocol, that figure shown at the bottom left in 2005, showed that crizotinib was actually designed as a MET inhibitor. And we do see activity here. This trial looked at mostly adenocarcinoma, included 60% smokers, 40% non-smokers. Here we see the response rate, 32%. The swimmer's plot showing some of these are quite durable. Median duration of response at 9 months, PFS at 7 months. MET, not FDA approved. Crizotinib, not FDA approved for METX14 non-small cell lung cancer, but it is compendium listed. We do have more selective inhibitors now. We see the activity of crizotinib for MET a little more modest than we see in ALK and ROS1, but these selective agents really do perform quite well. Capmatinib, studied in the phase 2 geometry trial. In that second and third line setting, response rate about 40%, median duration 9.7 months. Even better in that first line setting, where our response rate is closer to 70%, median duration of response just over a year. This drug FDA approved in 2020. Tepotinib, studied in the phase 2 VISION trial. The unique part of VISION is that it allowed patients to enroll based on liquid biopsy or tissue biopsy. Outcomes were pretty comparable between the two. Overall, response rate 46%, but it has that waterfall plot silhouette where most of the patients are deriving some benefit from therapy, fairly durable responses at 11 months. And as Tony mentioned, savolitinib, not US FDA approved, but approved in China for METX14 lung cancer, response rate 40%, again, that similar shape and fairly durable responses. Capmatinib and tepotinib are our approved therapies. When we look at these, while they have comparable efficacy, they also have fairly comparable toxicity. These I would consider as lateral, fairly equivalent agents. And you wouldn't necessarily expect one to overcome resistance of the other. When we think of side effects of these MET inhibitors, while we can see GI toxicities, elevation in LFTs, in my own practice, the limiting toxicity has been peripheral edema. And this does seem to be a class effect. We see most patients developing some level of edema. Capmatinib at 51%, tepotinib 56%, savolitinib 54%, crizotinib 51%. Only about 10% or less are grade 3, but a lot of these are grade 2, and grade 2 edema really can be impactful in our day-to-day life. And so most of my own dose reductions are due to peripheral edema. And we think of this generally as a class effect, one that is difficult to manage. They tend not to respond well to diuretics. In fact, I think all diuretics do are push the creatinine up even further. Compression stockings, lymphedema treatment, primarily just move that fluid around. Generally, what responds well is dose reduction for this severe edema. Amivantamab, as was mentioned, is a bispecific antibody that targets both EGFR and MET. At ASCO this year, Dr. Krebs updated the Chrysalis data, looking at 46 patients with METX14. We saw the response rate 33%, but that included patients that were heavily pretreated, many of whom had had prior MET TKIs. In the treatment-naive setting, at first-line space, the response rate almost 60%. Median PFS overall was 6.7 months. When we look at amivantamab, the rate of peripheral edema, only 24%, about half as much edema, 1% grade 3. Now one wonders, do we see less edema because we are engaging MET less? Do you have to see edema to engage MET? Or can we really parse out the activity and the toxicity? Because if we could, I think we could definitely push the dose higher and really more effectively block that, which hopefully lead to more durable responses, but that remains to be seen. So an early data set here, but certainly encouraging. The other important MET agent is telisotuzumab vedotin, or Teliso-V. This is an antibody drug conjugate. Now here we're looking at MET IHC positive, not METX14, and this was really explored in the Luminosity trial, which was updated at ASCO this year by Ross Camage. And what we saw here is 3 different cohorts. Teliso-V was explored in MET-positive squamous lung cancer. The response rate there, 11%, actually overall for squamous, and that did meet futility, so that's no longer being developed. It was explored in EGFR mutant lung cancer, and even at CMET high, response rate not cracking 20%, so that was also considered futile. The drug will only be developed in that EGFR wild type group, where the overall response rate was 36%. The EGFR wild-type CMET high response rate was over 50%, and that earned this drug breakthrough designation by the FDA. So not yet approved, but certainly encouraging. As was mentioned, the main toxicity we worry about here has to do with the payload, and that's neuropathy and fair amounts of dose discontinuations. That brings us to KRAS, the most common driver in lung cancer, present up to a quarter of non-squamous lung cancer. We can see it sometimes in squamous. Hard to know if that really does mirror the same biology, and a lot of heterogeneity here. Even within KRAS G12C, the co-mutations that are present vary quite significantly. G12C is the most common, the most relevant, represents about half of the KRAS mutations, making it about 13% of all lung adenocarcinoma. And as was mentioned, this is a smoking-related mutation. It was long felt to be undruggable. It's not a constitutively active kinase. This was really thought to be a battle we couldn't win. Fortunately, that did change with the direct G12C inhibitors. Fascinating stories behind these drugs, but we'll jump right to some of the data. The 2 that are the furthest along are sotorasib, or AMG 510, and adagrasib, or MRTX 849. Sotorasib studied in the CodeBreak study. The phase 1 study established a dose of 960 milligrams daily. I'll mention that's 8 pills a day. My patients don't let me forget that. But in 126 patients with G12C, we saw that they were heavily pretreated, 81% with prior chemo and prior IO. The response rate here, 37%. Now, I know it doesn't quite meet the response rates you see with ALK, with ROS. I don't know if those are the right comparators here. The standard treatment here after chemoimmunotherapy would be DOCI or DOCI-RAM, where our response rate really capped out about 23%, 37%, I think, an upgrade there. It behaves like targeted therapy. Rapid responses, time to response 1.4 months, so the first scan. They can be durable, reaching out to almost a year. We can see most patients getting benefit. Sotorasib showing clear benefit in G12C. Adagrasib, these data were updated by Alexander Spire at ASCO this year. The Crystal-1 study, looking at 600 milligrams twice a day. In 116 patients, we had 98% here with prior chemo and prior IO. Pretty comparable results. Response rate here, 43%. I think pretty similar. Fast responses, fairly durable. Survival in both of these trials, just over a year in that second, third line setting. When we look at the toxicity of these drugs, for those who've given them, primarily GI, diarrhea, nausea, LFT elevation, certainly you see some fatigue. And when you look at dose modification rates, they are quite a bit higher with adagrasib, 52% dose reduction versus only 22% modification with sotorasib. But the rate of discontinuation due to adverse event is identical in the 2 studies at 7%. Remember, these are all patients who had had prior immunotherapy. And one wonders, does that influence the toxicity profile? And would these numbers be a lot lower if patients were IO naive? We saw with EGFR high rates of colitis and pneumonitis after IO. We see with ALK high rates of hepatitis, with selpercatinib hypersensitivity reactions. Would we see a much more favorable tox profile if these drugs were used in the IO naive setting? And that hasn't been done yet. Based, however, on the fairly manageable toxicity, the unmet need, and the clear efficacy, sotorasib did receive FDA accelerated approval in May of last year. Adagrasib not yet approved, but under review. We do know a little bit about resistance, and it's as you might expect. In an early analysis of 38 patients, this was led by Mark Awad's group, we see acquired KRAS mutations, amplification, a lot of bypass mechanisms and some fusions, but primarily we're seeing alterations within that MAP kinase pathway, which is probably what we'd expect. And as these become more and more heterogeneous and redundant, these will be incredibly difficult, I think, to overcome. There are early signs of inhibitor-specific resistance. The H95DR mutations are associated with adagrasib resistance, but not sotorasib resistance. Now, does that mean there may be a role for sequencing these agents in very specific alterations? And if we look at our 68L mutations, while those do confer resistance to both adagrasib and sotorasib, it's in very different ways. And so just a reminder, while these are both direct G12C inhibitors, they are different drugs, and there may be things that can set them apart. Another thing that could set them apart is CNS. Nadagrasib does have certain modifications that may allow it to be more effective within the brain. A retrospective analysis showed that this is an unmet need, that almost half the patients with KRAS G12C do develop brain metastases. Preclinically, we did see efficacy with adagrasib in the brain, and in a very early report, 2 patients in a specific subset of Crystal-1, we did see CSF concentrations that are in the right range of 20 to 30 nanomolar, and we see in those 2 patients, we did see responses. We do not have data for sotorasib in untreated brain metastases. Patients enrolled in CodeBreak had treated brain metastases, and they performed quite well. However, I will tell you that one of our patients did have leptomeningeal disease with KRAS G12C and has responded quite well to sotorasib. We'll have to see until more data emerges. Another thing these 3 alterations have in common is while they're all established de novo drivers, while they're all actionable, they also can emerge as mechanisms of resistance. And if we take EGFR as an example, as Tony alluded to, osimertinib resistance can be mediated by MET, whether it's amplification or X14, by BRAF, whether fusion or V600E, and by KRAS, whether mutation or amplification. And often we can target these. Here's a BRAF V600E mediating resistance to osimertinib. This is one of my patients. We combined the BRAF and trametinib with osimertinib, and we're able to get a good response and clearance of the clone. I will note, however, that she then developed a RET fusion, and so it can be a moving target and almost is like spinning plates in some cases. And obviously we know MET can mediate resistance, these data from the TATAN study, osimertinib and savolitinib showing efficacy with MET amplification. This then studied further in the Orchard study, which Helena, you presented 2 years ago with a response rate of about 40%, leading to the much larger phase 2 Savannah study, which is still enrolling patients now. Close here with immunotherapy. Another thing that ties these 3 alterations together, that a retrospective analysis here, the immunotarget study led by Julian Mazieres, showed that all 3 of these can respond to immunotherapy. BRAF with a response rate of 24%, MET 16%, KRAS 26%, much higher than what we see with the fusions. Now, does this relate to smoking? An interesting hypothesis. Shown at the bottom left are V600E BRAF mutations, and what we see is that in blue, the patients who were smokers had a much better PFS than were non-smokers, which again begs the question, is BRAF V600E lung cancer different in a smoker and a non-smoker? Do we apply the same targeted paradigm that we've established over the past 10 years? Should we always use targeted therapy first, or are there some cases where immunotherapy really should be first? We know that we can see durable therapy, durable benefit with KRAS mutant lung cancer and immunotherapy. There are patients that we will cure with immunotherapy that have a KRAS G12C, and we wouldn't want to deprive patients of that opportunity. In BRAF V600E, the DreamSeq data presented a few months ago showed that in that setting, while TKIs are very effective, survival is better if you start with IO. Now, sotorasib only approved in that second-line space. Again, the benefit really in IO is undeniable, but is that increasing toxicity? And can we better identify the patients that are going to get benefit from IO, and maybe we should be using IO first in that group? Can we give these drugs together concurrently? That's the topic of ongoing studies. My suspicion is no. But are there markers of IO benefit? Can we tell who's going to be the long-term survivor so we can steer them in a different direction? Is smoking status the best we can do? Is there some other surrogate, some genomic marker as to who should get what therapy first? So right now, targeted therapy is available for BRAF, MET, KRAS. It is important then to test for all of these. And while BRAF and KRAS mutations pretty easy to find, really maybe even by PCR, METX14 is going to benefit from RNA-seq. Responses to immunotherapy can occur, and maybe we need to revisit some of these dogmas of targeted therapy and get a little more specific. Understanding and preventing resistance, always a challenge here. And while these 3 genes have targeted therapies, it's for specific alterations. We have very little for BRAF non-V600E, for MET amplification, that's been very challenging, and for other mutations, especially KRAS G12V and G12D, really early work, but nothing too active at this moment. And so with that, I'll stop. Thanks again for the invitation and for your attention.